Next is skin and soft tissue infection. So skin infection can be non-purulent and purulent. We'll discuss both. So what are the types of non-purulent skin infection? Most common organism, beta hemolytic strep. And remember, strep we can treat with penicillin cephalosporin. If it is purulent, MRSA. It can be abscess, fruncle, carbuncle, require MRSA coverage plus drainage. So non-purulent infection are erysipelas, cellulitis, necrotizing skin infection. So what are the risk factors? So in your history, you'll try to find out any trauma to the skin, any fungal infection. Does your patient have neuropathy, lymphedema, history of diabetes, immunocompromise, any vascular diseases? So for that, you can order vascular doctor of the lower extremities too. Erysipelas is infection of epidermis and upper dermis, mostly involve lower extremities and face. So infection of epidermis and upper dermis. So let's say this is dermis, subcutaneous tissue, epidermis. So infection of the epidermis and upper dermis. So it's more of a superficial infection. Cellulitis, when deep dermis and subcutaneous tissue is involved, deep dermis and subcutaneous tissue is involved. That is cellulitis. Necrotizing fasciitis, when below the dermis is involved, basically fascia and muscles. And it's more of a polymicrobial infection from Staph aureus. So polymicrobial, every infection will be there. Cellulitis and erysipelas, always unilateral. Erysipelas usually presents acutely, but cellulitis symptoms develop over days. Because it's more deep, the patient will not have symptoms acutely. Erysipelas has clear demarcation between involved and uninvolved skin. The patient can have redness, swelling, warm, vesicle, bulla formation, hemorrhage. They can have systemic symptoms like fever, chills. If it is a purulent cellulitis, like abscess, they will have redness, tenderness, fluctuation, nodule, possible systemic symptoms. And then necrotizing fasciitis, they will have rapid clinical course, severe pain, swelling, bulla formation, and they will have signs and symptoms of sepsis. And just keep in mind that diagnosis of cellulitis or skin infection can be missed in 1/3 of the cases. So this is cellulitis, unilateral. There is no clear demarcation between involved and uninvolved skin. So some of the area might be involved here, some might be involved here too. Misdiagnosed 1/3 of the time. So what are the tests you can order? You can order blood culture if the patient is septic. If there is a wound, you can order wound culture. ESR for inflammation, C-reactive protein to check inflammation, check lactic acid. You can do imaging, start with CT scan to demonstrate any gas in the tissue. And if it is there, then it's possible necrotizing infection and require surgical exploration. So if it is a non-purulent infection, the most common organism you have to cover is beta hemolytic strep. And if it is MSSA organism, methicillin sensitive, then you can use methicillin, you can use cephalosporin. If the patient is allergic to cephalosporin, use clindamycin. But let's say if the patient is septic and history of MRSA infection in the past, then you can add MRSA coverage too with vancomycin. Erysipelas, again, you have to cover the same organism, MSSA. So beta hemolytic strep and MSSA, you can use cephalosporin. If allergic, you can use Clinda, Bactrim, or linezolid. So patient respond in 48 to 72 hours, and duration of treatment is 5 to 7 days. Now, if it is necrotizing fasciitis, it is a polymicrobial infection. So gram positive, gram negative, MRSA. So MRSA will be there, Pseudomonas will be there, and Clostridium will be there too. So you have to cover gram positive with Vanc for MRSA. You have to cover Zosyn, Peptazo for gram-negative organism and anaerobic coverage, and you will add clindamycin for Clostridium perfringens, antitoxin. This require surgical evaluation. Now, purulent infections, you have to worry about MRSA. And once they are purulent, they require IND, incision and drainage. What are the indications for antibiotic? If the abscess is greater than 2 centimeters with cellulitis, they are septic, immunocompromised, they have IV lines, catheter, prosthesis, pacemaker, history of endocarditis in the past. So in that case, you will cover them for MRSA. We know what is the choice of MRSA, oral antibiotic, IV. We have both options available. And then IND, incision and drainage. So duration of treatment is 5 days, but it can be extended up to 2 weeks.